So in this section, let's talk about some psychiatric disorders which are associated with the puerperium. And the psychiatric disorders which we will specifically talk about in this section will be the depressive illnesses, mainly the non-psychotic postpartum depressive illness, and then we will talk about the psychotic illnesses, puerperal psychosis, and then what's the pathophysiology and screening of the psychiatric disorders. So psychiatric disorders are bipolar and depressive illness. Bipolar have like manic attacks and depressive attacks also. So this bipolar is the combination of mania and depression. So both can occur in the puerperal period. Mental health issues, usually there are even suicidal attempts. Patients, they are so bad, their mental health is so bad that they even do have the suicidal attempts or thoughts after the delivery. Multidisciplinary approach should be used for managing. If they need medical treatment, we should put them on the pharmacological therapy and also non-pharmacological approaches, which include the cognitive management and psychotherapies. All those should be considered. Counseling is very important after the delivery or with the psychiatric disorder of the delivery, especially if the outcome of the pregnancy is poor. The mothers need really help with all the psychiatric problems they can have. Pathophysiology of postpartum disorders. Psychological and biological factors, the history factors are also play an important role. If there is a history of psychological illnesses after delivery, that is very important because there can be a biological factor. Severe condition, usually the severe conditions are due to endocrine basis, which is due to changes in some hormones level. Changes in the cortisol level, oxytocin, endorphins, thyroxine and steroid hormones, progesterone and estrogen. So all these are different changes that can lead to the psychological problems. If it is severe, mainly it is due to the neuroendocrine based, and these changes are changes in the cortisol level, oxytocin level, endorphins, thyroxine and steroid hormone, progesterone and estrogen. Fall in estrogen lead to hypertension and mood disturbance. Hypothyroidism lead to depression, and progesterone changes lead to postnatal blues. So changes in all these different hormones are associated with psychiatric problems of the postpartum or puerperium period. Normal psychological changes during pregnancy. Postnatal, we have emotions and behavioral changes are usually with PINCs within 24 to 40 hours. There is overactivity, insomnia, mood elevation. So PINCs, which is common 24 to 48 hours after, usually the patient is hyperactive, excited, there is elevation of the mood. With that hyperexcitement, usually there is insomnia, which is difficulty in sleeping. So insomnia is postnatal. Then Blues are first 2 weeks after delivery, there is fatigue and depression. So after the initial phase of hyperactivity, or we can say the manic phase, when the patient is hyper, emotions are high, and they have mood elevation and insomnia. And then the blues, which is the period in the first 2 weeks after delivery, when the patient is depressed and fatigued. Panic attacks, low self-esteem, low mood episodes, guilt, hopelessness, suicidal thoughts, mood swings, change in affect, and there is biological symptoms, less appetite, early awakenings. All these are different changes that can occur after the delivery, and they are normal changes. These occur to most of the people. Initially they are excited, hyper, slowly the phase of depression follows, and then it takes a time to go away. Screening for mental health issues. Addressing certain questions are important. Guidelines by National Institute of Health and Care Excellence. These are some questions that should be asked. Screening question for mental health during and after pregnancy. So they should be asked at booking when the patient first come to see the doctor. At the time of the booking, it should be asked that during past month, have you often felt down or depressed or hopeless? These are the questions that should be asked, that gives the idea to the doctor that this patient might have vulnerability to go into more depressive phase. During past month, have you often been bothered by having little interest or pleasure in doing things? Are these feelings something you need or want help with? So these are some important questions should be asked to the patient. Postpartum non-psychotic depressive illness. So we said that we have non-psychotic depressive illnesses, and then we have psychotic problems associated with the delivery or in the postpartum. So non-psychotic depressive illness, depression in first year after delivery is common in 10 to 15% of the patient usually have depression in the first year after pregnancy or delivery. Severe postnatal depression, 3 to 5% have severe, but the milder is in 10 to 15%. Higher risk if history of depression is present. So higher risk, more patients have tendency if they have a history of depression. Recurrence rate is 50%. So if they have the history of depression after one delivery or pregnancy, there is 50% chance that they might have this problem in the next pregnancy. Clinical features are the gradual onset, presents after 6 weeks. Symptoms are early awakening and then anxiety, poor appetite, mood swings, suicidal thoughts, low energy, libido, and tearfulness and guilt. Thoughts of harming baby. So these are the non-psychotic depressive illness in the patients after delivery. Is 10 to 15% is milder, and then about 3 to 5% which are more. But it presents after 6 weeks. There is gradual onset of this depression, and these are some symptoms associated with depressive moods, low energy, thoughts of suicides, harming the baby. All these are present. Then adverse sequel of postnatal depression. We have immediate sequel, which is the morbidity and suicide, psychiatric morbidity, damaged social attachment to infant, and emotional disturbance of infants. So if the mother is so badly depressed in that time, usually it's very bad for the infant also. So there poor attachment between the mother and the infant. The bond between the two is very poor and weak. Then later on, there is even marital breakdown and social and psychiatric effect on child. Mental issues are present. Treatment is remedy of social factors, drug therapy, interpersonal psychotherapy, cognitive behavioral therapy, and non-directive counseling. So all these are the treatment options for the depressive illness of the after delivery. Then the psychosis, puerperal psychosis is even more. Psychotic disorders are more serious psychiatric problems, rarely present before third postpartum day, usually before 4 weeks. Abrupt onset, agitation, insomnia, there is confusion, sight loss, self-harm, depression, all these are associated with puerperal sepsis. But if you notice, this is more common in the early phase of the puerperium as compared to non-psychotic depressive illness, which is common after the puerperium, and it is gradual in onset. This is abrupt in onset. There is fear and hallucinations are common in psychotic disorders. People see things which are not present or which are not real. Risk factors is history of psychosis or depression or family history. Treatment is acute pharmacotherapy, treating mania with lithium carbonate. Antidepressants are used for this psychotic disorder. Electroconvulsive therapy or ECT. So this was all about psychiatric disorders associated with the puerperium. Thank you for watching sqadia.com.